Welcome everybody to the Francisca Genitourinary Oncology Tumor Board. My name is Brian Reaney. I'm a professor of medicine at Vanderbilt Ingram Cancer Center in Nashville, Tennessee. And I'm pleased to be joined today by a panel of experts, and we're going to talk through a number of kidney, bladder, and prostate cancer cases.
My name is Jason Abel. I'm a surgeon. I'm a urologic oncologist and associate professor at the University of Wisconsin.
My name is Maha Hussain. I'm a geomedical oncologist. I'm a professor at the Robert H. Lurie Comprehensive Cancer Center, Northwestern University, and I also serve as the deputy director for the Cancer Center.
Hi, I'm Tyler Fromm. I'm an assistant professor of radiology at the Washington University School of Medicine in St. Louis. I specialize in abdominal and pelvic imaging as well as nuclear medicine. I'm glad to be here.
My name is Preetash Patel. I'm an associate professor of radiation oncology at the Winship Cancer Institute at Emory University, focusing on GU malignancies.
75-year-old African-American male who has a history of clinical T2 low-risk prostate cancer diagnosed many years ago in 1994. Got a radical prostatectomy, lymphadenopathy at the time. So, noted biochemical failure about 3 years later and got salvage radiation to the prostate bed and long-term hormones that ended in 2000. So I guess that would be 3 years. Recurred in 2001, managed with androgen deprivation therapy and multiple systemic therapies. Now has multifocal progression, both bony and retroperitoneal lymph nodes. And so this case is really about that management of that very refractory patient. We're going to go through this patient got, I think, most of our known treatments and how do we approach such a patient. So just to go back, this patient presented in 1994 with an elevated PSA, good performance status, type 2 diabetes and hypertension, social history, unremarkable, has a family history of a brother with prostate cancer diagnosed at a young age at 51. Then remember, this is 1994. He had low-risk prostate cancer. There's the initial PSA, Gleason 3+3 and 5 to 12 cores. He had surgery at pathologic T2N0 disease with negative margins and postoperative PSA undetectable. That's all good. PSA is followed, and 3 years later, he has a biochemical failure with a PSA of 1. You see that he completed salvage radiation and long-term androgen deprivation therapy. So let me, Dr. Patel, I'm going to ask you about the dose of radiation. Again, remembering this is 1997 and how that might compare to today, and also around the use of hormones with radiation in a salvage setting. Who gets it? Does everybody get it, and for how long?
Yeah, great questions. You know, in 1997, it was a little before the trials using ADT concurrent with radiation in this setting were even published. So this was sort of forward thinking, which was great. But RTOG 9601, which started in 1996, was a trial that used long-term ADT with salvage radiation, which did show a survival benefit, distant metastasis benefit to the use of ADT along with radiation. This was the dose in that study. You know, in general, I think this sort of older study sets the stage for using ADT and with salvage. There was a post hoc analysis done of that study, which showed that the benefit of ADT seemed to be confined to a group that had a slightly higher PSA pre-salvage radiation. So 0.6 is a post hoc cut point. And we tend to use that clinically as a deciding factor as to when to add ADT in this setting. Actually, other cause mortality was worse in patients with lower PSAs when the ADT was added. That being said, in that study, it was an anti-androgen and not an LHRH agonist, so that may be a little different. And then a more recent study, the SPORT trial, has looked at the addition of both short-term ADT and pelvic nodal radiation, or both, in the setting of salvage radiation. This trial does seem to show a benefit really for the escalation in both ways, the addition of short-term ADT and the irradiation of lymph nodes. And so really at this point, I think you could make the case with these data to add ADT or pelvic irradiation to almost anybody who's coming for salvage radiation based on the inclusion criteria of these studies. That being said, I think, you know, the post hoc analysis, we use the 0.6 PSA cutoff for the addition of ADT. And then for someone who's had a good pelvic lymph node dissection, that may be a good way to decide on whether the pelvic node should be irradiated or not, or if they've even had a pelvic lymph node dissection. And then, newest, I think now in our workflow is to, of course, include PET. And so at our institution, we have a trial using PSMA or FACBC. And really, we've got, really an institutional study where we use the PET for really defining the targets. So we don't treat the lymph nodes unless they're positive on the PET.
So I think this whole area with the advent of PET is probably being re-examined. I actually want to back up a little bit and bring our surgeon, Dr. Abel, into the discussion around the lymph nodes. This patient had 8 lymph nodes removed, it looked like. I honestly don't know what's standard for lymphadenectomy and prostate cancer and how that's decided. And Dr. Patel mentioned the adequacy of lymph node dissection, but I'm not sure that I actually know what a definition of an adequate one is. So Dr. Abel, can you comment on that, on how that's decided in the setting of prostatectomy?
Yeah, I think that is a good question, and it's something that doesn't have an exact answer. So when you look at the number that you count, that comes from the pathologist looking in several serial sections. Now, people have done studies, if they send them in separate packets, they get higher counts, even though if it's in the same anatomic section. So it's really hard to say based on just the number. And several studies have looked at this. And when they do studies looking, whether an extended node dissection, so something farther up, even outside of the pelvis, changes outcomes, they're actually using pictures to define the adequacy of lymph node dissection. So it's really, really difficult to say just based on the lymph node count what the number is. That being said, I said somewhere typical would be, 8 would be a little bit low, somewhere low single digits would be typical for most tertiary centers. But the idea of an adequate lymph node dissection really is in the eye of the surgeon doing it. And it's really not standardized throughout the country or the world.
Okay, thank you for that answer. I'm glad that I didn't know what the answer. That answer makes me feel better that I didn't know what the number was. So this patient now, it's 2001, so sorry. So 97 gets salvage radiation and hormones, stops hormones, I guess in 2000. So it looks like in 2001, so probably with recovery of testosterone, then has further PSA rise and gets an indium scan that showed abnormal uptake to a left internal iliac node, and he's restarted on hormones. And before we go on, I'm going to ask Dr. Fromm to comment on this indium scan, which I don't know anything about.
So indium caprimab pentatide, the brand name is Prostascent,
Okay.
and it is an old imaging agent that is a monoclonal antibody directed against an intracellular epitope of PSMA, which is a transmembrane protein overexpressed by prostate cancer. The problem with this agent, well, there are multiple problems with this agent. One is that because it targets an intracellular epitope, it can bind only to dying prostate cancer cells. Otherwise, the antibody cannot traverse the membrane and bind to that epitope. And then also, it is a SPECT agent. So the quality of the images that we are able to create using this agent are sort of far inferior to what we can achieve with PET, and that just has to do with the technology involved in creating a SPECT image versus a PET image. So it was really the only game in town for some time, but far inferior to choline FACBC, PET-CT, and certainly PSMA PET as well.
Okay. Thank you. I did know the Prostascent name, didn't know its real name. So this patient gets restarted on hormones, does well for 4 years, then has further PSA elevation, gets bicalutamide added to the leuprolide. Just to cruise through, you can see over the next couple of years, multiple sequential agents goes through. Flutamide has further soft tissue and bony progression. Gets chemotherapy with docetaxel for 10 cycles back in 2010. Gets cabazitaxel for 16 cycles. This is a particularly tough patient. A year later, abiraterone then in 2012 to 16. I don't remember its year of approval. This patient may have been on a trial. PSA was low at start, ultimately rose to 6.6 over the 4 years. Continued PSA elevation, progression on a bone scan, was changed to enzalutamide for a couple of years, looks like till late 2018. Further progression of osseous metastatic disease, and referred to radiation oncology with this further sort of bony, presumably symptomatic progression. And then a graph of their sort of PSA history and some of the treatments, but obviously this patient was on multiple, almost pretty much everything possible at the time. If we just turn now to the question, so I've sort of listed here the total list of treatments that this patient has gotten. So this patient has multifocal bone and soft tissue, presumably somewhat symptomatic metastatic disease, status post and palliative radiation, and you can see the laundry list of agents there. So maybe Dr. Hussein, this probably isn't terribly uncommon to show up in your clinic as a referral, a patient like this. How do you think about this patient in terms of what the treatment options are moving forward?
I should point out that he has gone through an amazing cycle of life, because if you think about when he became castration resistant and got the docetaxel and the rest of the treatments until now, we're talking here many, many years, which is a very unusual setting. I think that in his case, pretty much standard of care has been exhausted. Clearly, depending on the extent of the soft tissue disease and how bulky it is, obviously, if it's not huge and not visceral disease and things like that, I think radium could be an option potentially. If in fact, again, it's not, bulky disease and otherwise visceral disease. His other option, definitely, this is the kind of patient that you either would do a biopsy or do circulating biomarker evaluation to see if there is the potential for targeted treatment. I want to also remind the audience that there are some other chemos that we used to use in the past. Unfortunately, they're not life prolonging. And sometimes I see patients being offered cyclophosphamide, mitomycin, things of that sort. So the reality of it is if these are not life prolonging, and we have much better tools right now for palliative services for the patients. So I think a clear conversation with the patient about his goal in life, what kind of health he is in, and then definitely exploration of potential for clinical trials. And definitely, I would say NGS would be important in this situation, because you may end up getting sort of the NF1 type setup where you could actually offer the patient a compassionate use or part of a clinical trial, the option for targeted treatment.
Sure. Do you ever use
the other thing I should point out is that the FDA has approved immunotherapy in patients with prostate, well, it's not specifically prostate cancer, but patients who are MSI-high and so on. And obviously you're the expert on this area, but definitely that would be one of the advantages in terms of checking in terms of doing the biopsy.
So just to summarize this case, the good news is that patient has lived a very long time with castrate-resistant disease and sort of benefited from the development of agents that occurred during his disease course. Next generation sequencing, genomic testing of some sort seems like a good first step in this patient to identify something responsive to a PARP inhibitor, clinical trial option, MSI, microsatellite instability for immunotherapy options, or just another sort of phase 1 clinical trial. But these patients can be remarkably good performance status. They often look much better in person than on paper.